עכשיו, לאחר שסעדנו וסבלנו, נוכל להמשיך בתוכנית הכנס ולפתוח את המושב השני בהרצאתו המרתקת של פרופסור אריק הופמן. פרופסור הופמן, חוקר דושן בעל שם עולמי משנת 1986, היה חבר צוות בבית ספר לרפואת ילדים בהרווארד בראשותו של דוקטור קונקל. הוא פיתח אבחון מולקולרי ומודלים פיזיולוגיים של DMD, ולאחרונה עסוק בפיתוח טיפולים עבור 3 חברות שמתמקדות בחקר הדושן. בכנס זה, בניגוד לכתוב בתוכנית הכנס, יש קצת פידבק, אפשר... תודה. מופיע פרופסור הופמן כמנכ"ל חברת רוורagin ביופרמה, וכן כפרופסור לפרמצבטיקה באוניברסיטת בינגהמפטון שבניו יורק. אנו מתנצלים על הטעות. פליז, פרופסור הופמן.
Thanks. What I'll be speaking about is a new type of drug. It's a new class of drug called vamorolone. It was previously called VBP15, and it has multiple activities, and I'll go through those. Just some disclosures that I'm involved in a couple companies and schools. So as was just mentioned, the gene and cause of Duchenne was first found in 1986-87. It was a group of 4 of us that worked together. And it's the largest gene known and has a very high mutation rate. Why I bring that up is that early on, right after we found the gene, we tested a bunch of muscles from patients and also from newborns with Duchenne and also even took fetal life. And we found that dystrophin was missing from fetal life onwards, and the heart is missing dystrophin from fetal life. And so dystrophin doesn't change as a function of age in either normal, healthy individuals or in Duchenne patients. But the disease is progressive. So even though dystrophin doesn't change, it's always absent from fetal life. Why is the disease so progressive? And so helping us understand that was finding when owners brought pets in, they brought cats, they brought dogs to us and said, we have a dog with a muscle problem or a cat with a muscle problem. Can you test the cat to see if it has Duchenne muscular dystrophy? And we did, and this was a cat that we found very early on, brought in by owners. And you can see in the middle there, the affected cat had 0 dystrophin in the middle from that lot. So the cat also, can you turn this down a bit? Thanks. Can you keep it down? So when we looked at the muscles of the cats there in the chart, the cat's muscles that had Duchenne were double the size of normal cats. So they had twice as much muscle as normal cats. And we found many cats, and they were all like that. They were like super cats, like weightlifter cats. They didn't get weak. They didn't get loss of muscle. And I'll show you what these cats look like. So they have enormous necks, they have big muscles. The picture of the muscle is the diaphragm that goes underneath the stomach. It's a very thin sheet of muscle. In the cat, it got so big that that became a health problem. And this is no fat or fibrosis in the muscle. The muscle looks quite healthy. It's missing dystrophin. It has Duchenne dystrophy. Well, the same thing with some human patients. And you know this in Duchenne kids. They can look like bodybuilders when they're young, but then some muscles begin to waste and get small, and other muscles are big. And these are muscles from mice missing dystrophin. The top one are normal mice. The bottom ones are mice missing dystrophin. They get huge. So a key immediate consequence of dystrophin deficiency is not weakness. In fact, it's very large, strong muscles. It's only later in age that the muscle changes from too big to wasted and weak. And that changes very differently for each muscle in a Duchenne kid. Some muscles in Duchenne stay very large and strong, like the sartorius, very long, late into life. The heart stays very strong, very late into life, but they're all missing dystrophin. So why the different response? So what it suggests is that, well, here's another example of the dogs missing dystrophin, also get very large muscles, some of them like human patients. And when you start taking myostatin, you heard earlier about a myostatin trial, if you start reducing myostatin in the dogs, the red muscle there gets hypertrophied in missing dystrophin. It gets even bigger missing myostatin. It gets supernormal. But other muscles, like the yellow one, are getting smaller with missing dystrophin and even smaller missing dystrophin and myostatin. So the key thing is that Duchenne muscular dystrophy, dystrophin is not sufficient for weakness. It's only a later stage of the process that causes weakness. Okay, so that gives you two different avenues to therapy. So here's just a summary. Dystrophin deficiency initiates a series of cellular pathologies. Immediately, those are membrane instability, muscle hypertrophy, too big, inflammation, and focal degeneration regeneration. But then it's only after years of chronic damage that you get fibrosis and weakness. So deflazacort and prednisone attack the inflammation. That's why they work in Duchenne. And I'll talk about a different drug that attacks multiple aspects of this progression called vamorolone. Exon skipping and gene therapy, as you've heard, go after the top part, replacing dystrophin. Obviously, if you can replace dystrophin, but that would be normal dystrophin. If you can bring normal dystrophin back, you'll stop the disease. But I have to remind you that both gene therapy and exon skipping are not normal dystrophin. They're highly abnormal, Becker-like dystrophin. So we really don't know how much they're going to stop the disease at the top. So even with gene therapy, even with exon skipping, you still have to address the second part, because Becker muscular dystrophy also has that part going. So there's drawbacks with both dystrophin replacement and with corticosteroids. With dystrophin replacement, it's not normal full-length dystrophin. You have Becker-like or mini dystrophins. They're semi-functional, and innate immunity and fibrosis cascades still occur. Corticosteroids are likely important as an add-on. Corticosteroids, on the other hand, have many side effects: bone fragility, endocrine growth stunting, muscle atrophy. The side effects are dose-limiting, which means you can't give more steroids, you just get more side effects. And they worsen membrane instability. There's more and more data that we know that we have unstable membranes when you're missing dystrophin. They leak, that's why you have CK in the blood. Prednisone makes that worse. So prednisone does many different things. They're making some parts of the disease better, some parts of the disease worse. At the end of the day, we'll probably see both dystrophin replacement and anti-inflammatory with less side effects are probably going to be a combination treatment in the next couple of years. So corticosteroids were the fastest Nobel Prize ever awarded. There were 14 arthritis patients treated, and 2 years later they awarded the Nobel Prize in 1950. The Nobel Committee noted, great, but need to do something about side effects, and you're familiar with many of these side effects. DMD is almost defined now by corticosteroid treatment, the cushingoid treatment, the stunting of growth, and the brittle bones. So the goal of the vamorolone program is to understand all the layers of the onion of corticosteroids, keep or improve the good parts of the onion, and get rid of the bad parts of the onion. I do a lot of cooking, and so I see onions like that, and I try to save what's left of the onion. So we have corticosteroids are potent anti-inflammatory drugs. They have two activities, what's called transactivation and transrepression, and I'll quickly describe how we developed this drug. Let me skip over that. So we developed a drug, vamorolone there, the structure of the drug is shown in red, prednisone is shown in blue. It's a very subtle differences. If you look all the way over on the left there, there's an O, an oxygen at the top that's changed to an H, and that causes a kink. Now what we've done is look at what that does to the binding to the receptor. Corticosteroids have proteins that they bind to that mediate their effects. And so we solved the X-ray crystal structure of what that actually looks like. And you see with prednisone, there's a red arrow where a key contact of the drug with the protein receptor, and in vamorolone, we lose that, which twists the drug a bit. So we've gone further and then solved how the drug actually fits into the receptor and interacts with it. And then we compared prednisone to vamorolone. And this is the last complicated data slide I'll go, and then I'll finish with clinical trials. But the drug there is nestled in the receptor with the yellow arrow. And the difference between prednisone and vamorolone is those red coils are pushed out by vamorolone. And when it does that, it changes key protein binding called coactivators and co-repressors. These are other proteins that need to come in and stabilize the drug receptor complex and carry out its actions downstream. Co-activation is bad. That's mostly side effects. Co-repression is good. That's mostly the anti-inflammatory efficacy. We change the binding of those two. So we cut down on the co-activation, which is the bad, and we increase the co-repression, which is good. We also add another activity that's different than prednisone and deflazacort, is we create what's called a mineralocorticoid antagonist. That is the same as eplerenone, which is given to many Duchenne kids as a cardioprotective drug, and is shown to show efficacy. Prednisone and deflazacort do not do the same thing as eplerenone. They actually can do the opposite, whereas vamorolone does exactly the same as eplerenone. So here you can see in mice, MDX mice getting a cardiac disease, and vamorolone completely protects against that. So it's switched the activity here away from prednisone and deflazacort. We also stabilize plasma membranes, which prednisone and deflazacort do not do. So in summary of what we've learned about this drug preclinically before we headed into patients, vamorolone is a first-in-class steroidal drug. It is not a glucocorticoid or corticosteroid. It's a different class of drug. It changes interaction with the receptor, with structural effects on coactivator repressor domain. Co-repressor binding is increased, so anti-inflammation is retained or increased. Co-activator binding is decreased, so that safety is potentially improved. It's a mineralocorticoid antagonist, which is new potential heart benefit. Membrane stabilization is increased, so new potential protection against dystrophin deficiency. And in many mouse models of many diseases, including Duchenne, we see this drug works as well or better than deflazacort or prednisone. So these are the clinical trials. We started in 2015 with adult volunteers, 2016 with Duchenne muscular dystrophy children. Tel Aviv and Yoram Nevo here has participated, was founding member of the Synergy Network, and has participated in all these trials. So a number of Israeli patients are entered into these. There's a phase 2A extension, long-term extension, and now we're enrolling into this blinded study. And we should be going to drug approval with FDA and EMA next year once we finish this last trial. So in the 6-month study, here we studied 4 different dose groups. 0.25 is a very low dose, 0.75 is about the same as prednisone, then 2.0 and 6.0, which are about 3 to 8 times more than prednisone. And here, time to stand, where if the line goes up, the patients are improving, so they're getting better. Not stabilizing, they're getting better. And you see there's a clear dose effect. With low dose, they're not getting better, slightly worse, but as you increase the dose, the patients are getting better. We can then use a natural history study that was done a long time ago. Again, I think Yoram participated in that, the Synergy DNHS. It's sort of in the middle there, and that's statistically significant. This is now time to run walk 10 meters. You can see after 6 months, many of the patients are dramatically improving. Again, not stabilizing, but improving. And the natural history study is there near the bottom. This is the 6-minute walk test. Again, dose response. So low dose, patients get a little worse, but as the dose increases up to 8 times prednisone dose, you see these effects, and that's about a 45-meter improvement over 6 months treatment. North Star Ambulatory is the same, a dose-dependent improvement. So now new data is those patients, it seems the patients and the physicians are happy with vamorolone. The patients on the high dose want to keep on continuing. The patients on the low dose want to dose escalate to the high doses to get benefit. So we have what's called a long-term extension, and that was a 2-year study. We've finished half of that now, and all patients will be finished next year after 2.5 years of vamorolone treatment. So what I'll show you now is 18 months of high-dose vamorolone treatment and the effect on the children. So what this looks like in schematic is in the first study, they were 2 weeks on, 2 weeks off. 6 months in the extension. I already showed you that data. Now I'm in the long-term extension, and we're halfway through that. So now this is each dose group, and so how you see here is the 2 high doses are the red and the blue. The 2 low doses are the orange and the green. The first dose group started at low dose, and once they hit the 2-year long-term extension, they started dose escalating and going higher and higher. And so right now, half those patients are on 2 and half are on 6. The second dose group started at 0.75, and then immediately dose escalated to the 2 high doses, and half are on 2 and half are on 6. The third dose group started at 2.0 mg per kg, the blue, and then half escalated to 6. Since that third dose group has now been 18 months on high dose, where we're seeing good effect, I'll show you data for that. The highest dose group where everybody stayed on the high dose, we don't quite have that data. Just yesterday we had the last patient come in, so I don't have that to show yet. Okay, so this is time to stand on those patients. You see when they started the study, their amount of seconds it took to stand was between 3 seconds and 9 seconds. You see when they started taking vamorolone, they all started getting faster. So you see that they all dropped below 5 seconds except for one patient. 5 seconds for time to stand is quite important because in big studies of the natural history studies of 400 patients, we know that if it takes less than 5 seconds to stand from the floor, you're going to be stable or improve over time. You won't get worse. So by improving those patients under 5 seconds, that moves them all into another dose group of stable or improving. And there we've just shown as velocity based on their own baseline, just a different way of looking at the same data. And here I describe that and look at the other 2 dose groups. So milestone group 1, time to stand less than 5 seconds, a threshold value of approximately 5 seconds differentiates between patients who are likely to show stability or improvement versus those who are likely to decline. Milestone group 2, time to stand between 5 and 10 seconds, patients with stand from supine values of 5 seconds or longer are likely to experience decline in function and possible loss of standing ability, but not at imminent risk for loss of time to climb 4 stairs or ambulation. So here are those 3 dose groups. The first dose group that dose escalated late, you can see they've only had 6 months of treatment at high dose, and they're actually getting a little worse. The second dose group, the red, was treated for a year at high dose, and they're stable. The green has been treated for a year and a half at high dose, and they're improving. So you clearly see the longer you're treated, the better you do. Here's North Star. North Star is these 17 tests. I'm sure many of you are familiar with that, and they are on a 0, 1, and 2 grade for each test. You can see that patients, when they came in, were between 14 and 28 for the North Star, and you can see that after 18 months of treatment, they're all improving. So this is an average of 5 points or more of improvement on North Star. That means for 5 of those 17 tests, they got better. So they could hop on 1 foot or they could stand quickly without assistance. And here again, you see the length of treatment, 6 months high dose, 12 months high dose, 18 months high dose. The extent of time you're on vamorolone causes increased improvement over 18 months. And remember, without any of these drugs, patients would be declining. It's a 6 meters minute walk in meters, and again, the improvement over time. You see over 18 months, only 1 of 9 patients there showed any decline. The rest showed improvement or stabilization. I'll skip over that. So now I'm going to go to safety, the side effects of corticosteroids. So what side effects are viewed as important to DMD families? We did a survey of 91 families, and this is the ranking. So most important is loss of bone density, weight gain, suppressed immunity, mood and behavior, and stunting of growth. So now we've looked at these with vamorolone-treated patients. First, let's look at stunting of growth. That's this last column. So change in height percentile over a year. So if the number goes negative, that means the drug is slowing growth, and the children is no longer growing. And so you see with both deflazacort, lots of stunting of growth. Prednisone, a little less, but still a lot of stunting of growth. That's consistent with a natural history study with the Synergy DNHS, where we looked at physician-reported side effects of steroids, and growth delay were significant both for deflazacort and prednisone. With vamorolone, we see no stunting of growth. In fact, the kids are growing slightly faster than they were without the drug. It could be because their muscle's more stable. So we've lost the side effect of growth stunting. We looked at bone biomarkers in the blood. Osteocalcin is a marker for bone formation. You just do a blood test. With prednisone and deflazacort, that quickly goes down within hours of the first dose. It correlates with loss of bone density. Vamorolone, it increases osteocalcin instead of decreasing it, so it does the opposite. So that, coupled with the height, lack of growth stunting, suggests that the bone morbidities are probably lost with vamorolone. If we look at cushingoid, you see again the high rates of cushingoid, the swelling of the face, and again with vamorolone much less. And if we look at weight increase, high amount of weight increase, and much less with vamorolone. Do I have this slide? Yeah, with weight increase, it's interesting. So here's two of the dose groups, and we're looking at change in BMI over time. Most of the kids are quite stable, but you see one or two or three kids that show quite a bit of weight gain. So we're seeing a subset of Duchenne kids on vamorolone long-term that show some weight gain, but it's about 10%. Those same kids may come, it seems when we ask the physicians, those same children, their families also have a tendency to grow large. And so it may be a predisposition in there, and we have to study that further. So in summary, we have a dissociative steroidal anti-inflammatory drug. Vamorolone shows dose-dependent efficacy in DMD. This is an open-label study, but we see this dose response, which argues against placebo effect. We see improvements in gross motor function tests, significant within trial and between dose groups, significant in comparison to natural history, steroid naive. At 6 months, improvements similar in magnitude to corticosteroids. 18-month comparisons to steroids we're currently doing, so we'll know that in a month or two. Vamorolone shows no dose-limiting toxicities, no drug stoppage due to safety concerns in 48 DMD boys to 9x prednisone dose. And we have about 50 patient years of high-dose drug exposure in DMD at this point. And we're currently seeking patients for a double-blind comparison to placebo and prednisone. So this trial that Yoram is currently enrolling into is patients are brought in and they're randomized into 4 groups. You don't know which of 4 groups you are. It would either be vamorolone at 2 mg per kg, vamorolone at higher, 6 mg per kg, placebo, or prednisone. Now, there's about 25% placebo chance to be placebo, 25% for prednisone, but that's only for 6 months. After 6 months, everybody moves to vamorolone. And then we provide vamorolone long-term. So we have extended plan. As long as the patients want to take vamorolone, we provide that for free. These are 4 to 7 years steroid naive, all traveled, stayed to one of 33 sites in 10 countries covered. Visits are about 1 per month. Dosing is done in the morning at home. It's a liquid formulation. Of the 120, we're about 20% enrolled. And we don't have a booth here. That was from another meeting. And these are the sites that are enrolling. But most important is Dr. Nevo, who's been a long-term friend and collaborator at Schneider Children's Hospital. The sooner we can get kids enrolled in this, the faster we can go to approval, and the faster, hopefully, we can replace deflazacort and prednisone and remove a lot of those side effects. And that can be used then in combination with gene therapy or other methods in the future. Acknowledgement, Paula Clemens at Pittsburgh and Michaela Guglieri at Newcastle, the study chairs. This trials use the Synergy Network. Financial support was from UC and European Commission governments, 12 nonprofit foundations. And these are the different foundations that have supported the vamorolone program to date. Thank you. Any questions? Any questions? Yeah. The question, I think, is why are we doing a blinded study if we already have all this data showing improvement? Is that what you're asking? Natural history. Right. So the question is, given the data I showed and that we have natural history data, why can we get approval now? I guess that's the question, instead of going ahead and doing a blinded study. So it differs for EMA and FDA. And so we've talked about this to both, and we're doing it in parallel for both FDA and EMA. The FDA is very, very fixated. They almost demand a placebo-controlled trial. Now, they're not doing them in exon skipping, or at least not before drug approval. That's because they have dystrophin as a surrogate outcome. So if you have a surrogate outcome measure, a biomarker, that's accepted by FDA, you can avoid the blinded part because it's considered objective. And dystrophin was used in that case. We're not trying to increase dystrophin levels, so we don't have that surrogate biomarker. So FDA really insists on a placebo-controlled trial. EMA is more willing to consider comparisons to natural history studies, and with what's called provisional or conditional approval, that you do a blinded study later, post-approval, post-marketing. We're going to talk to them about it this summer. So maybe it's possible it could get approved in Europe, and then we could use the blinded study. We'd still need the blinded study post-marketing, we'll just do it early. And we'll probably have it finished by the time. So the timing difference is not that great anyway, since we plan to be fully enrolled into the blinded study by the end of this calendar year. And then we've already have agreement from FDA that we only need 6 months of data to go to approval. Yeah. So the question is, can we or should we do combinations with gene therapy? So first of all, as all the speakers have mentioned, gene therapy is an add-on to corticosteroids. So in fact, they increase the amount of corticosteroids with gene therapy. They don't decrease it. And that's because it's needed for both the anti-inflammation, because it's Becker, it's not normal dystrophin, and also because you need to prevent rejection of the virus. Okay, so gene therapy as well as exon skipping are what's called an add-on or combination to corticosteroids. So vamorolone would just generally replace corticosteroids. And so to that extent, gene therapy and exon skipping would become add-ons to vamorolone.